Hi Brian, it's Marisa, and today I am reporting to you on RT, who is a 54-year-old man who presented to the clinic with complaints of depression, mild shortness of breath, trouble breathing, and trouble breathing with exercise. History of present illness shows RT reports he suffered a terrible depression since his heart attack in 2015, and he has been depressed consistently for the past 6 months, which he describes as constant feelings of guilt, fatigue, and worthlessness. He is less interested in spending time with his friends and hobbies, and he has difficulty concentrating at work. His depression is particularly difficult in cold weather and during the holidays, and was previously treated with citalopram about 2 years ago, which worked well, but he discontinued due to erectile dysfunction and diarrhea. He is actively seeking to treat his depression, and he desires to take control of his life again. He states he is willing to try to quit smoking, and if he could breathe a little better, he is willing to start an exercise program. Mild wheezing is evident on presentation. He gained 15 pounds over the last 6 months, and he has been eating more over the last 3 months. Pertinent past medical history are COPD exacerbation in March of 2017. He had a STEMI 3 years ago, which was attributed to his lifestyle habits, depression, obesity, dyslipidemia, and he currently smokes 1 pack per day. His family history is significant for cardiovascular disease and depression. His medications include metoprolol 50 milligram daily, fluticasone 100 microgram, 1 inhalation twice daily, albuterol 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 milligrams orally daily, aspirin 325 milligrams orally daily, and he received the 23-valent pneumococcal vaccine and influenza vaccine in March of 2017. And he has an allergy to adhesives. His prioritized problem list includes uncontrolled depression, uncontrolled COPD, uncontrolled obesity. He has an increased QTc interval with EKG from today, and renal insufficiency and elevated hepatic enzymes. For assessment of his disease, starting with the COPD, he has no signs of bronchitis. He is saturating well on room air at 95%, and his respirations there at 18. His FEV1% predicted post-bronchodilator is 52%, and severity of airflow limitation classification in COPD is moderate or gold stage 2, where FEV1 is greater than 50% but less than 80% predicted from the gold guidelines. Using a CAT score of 21, his risk of exacerbation and his symptoms, his combined COPD assessment places him in patient group B, which is low risk and more symptoms, and he should be considered for regular treatment for his symptoms. The goals of therapy are to treat and prevent his exacerbations, reduce long-term lung function decline, reduce hospitalizations and morbidity and mortality, relieve the disabling dyspnea, improve exercise tolerance and health-related quality of life, and to assess and treat comorbidities routinely. At this time, the fluticasone metered-dose inhaler therapy is suboptimal. The recommendation for reassessment of COPD is appropriate from the physician, and a patient-specific optimization of inhaler regimen is appropriate. And smoking cessation plan is appropriate for this patient. However, use of nicotine patches is inappropriate because the patient has the allergy to adhesives. So for the plan for RT, starting with the COPD, I recommend smoking cessation with nicotine mini lozenge over the counter. The dose will be determined based on the timing of his first cigarette of the day. He can start with 1 lozenge every 1 to 2 hours for 6 weeks, then 1 lozenge every 2 to 4 hours for 2 weeks, then 1 lozenge every 4 to 8 hours for 2 weeks, with a maximum of 20 lozenges per day. For safety, we'll advise the patient to report any unexpected or untoward side effects that he deems that are related or associated with the lozenge. For efficacy, we'll look at the ability for the patient to stay on track with the standard trial of the nicotine mini lozenge and successfully quit smoking. I recommended follow-up with a phone call in 3 to 7 days for approximately 3 minutes of counseling to assess their smoking cessation progress and provide support. And the rationale here is that a brief 3-minute counseling to urge quitting improves cessation rates by 5 to 10% per GOLD guidelines. For non-pharmacologic therapy, I recommended to refer the patient to a smoking cessation support group or counseling programs, to begin healthy routine habits when they have the urge to smoke, such as brushing their teeth, walking, stretching, mindful thinking, or meditation for approximately 10 minutes. For patient education, the patient needs to allow the lozenge to dissolve over 10 minutes. Do not chew or swallow. They may feel a warm or tingling sensation while the lozenge is dissolving, and they should occasionally rotate the lozenge in their mouth while it's dissolving. No food or beverages 15 minutes before or during use, particularly acidic drinks such as coffee, juices, and soft drinks. And the treatment duration with the lozenge is 12 weeks. Also advise the patient that their first attempt to quit smoking may not be successful, but they should continue with their progress for quitting. For patient-specific optimization of inhaler regimen, recommend discontinuing the fluticasone 100 microgram inhaler and start a combination long-acting beta-2 agonist and inhaled corticosteroid meter dose inhaler, the Advair Discus 100 per 50, which is fluticasone 100 microgram and salmeterol 50 microgram. 1 puff orally in the morning and evening every day, separated about 12 hours apart. And the FDA approves the Advair Discus for COPD. Also, the patient should continue their short-acting beta agonist, the albuterol. For safety, we're going to look at or have the patient report heart rate and blood pressure, any worsenings of their symptoms despite the treatment. For efficacy, we will look at resolution of their wheezing, increased exercise tolerance, and hopefully some weight loss. I recommended a 30-day follow-up appointment to recheck inhaler technique, evaluate the symptoms, and reassess quality of life. Also determine adherence with the inhalers and possibly repeat spirometry, although that might not be necessary. Non-pharmacologic therapy is referral for pulmonary rehabilitation, and the rationale here is to reduce their symptoms, improve quality of life, increase physical and emotional participation in daily activities, decrease hospitalization length of stay, improve survival, and improve recovery after hospitalization if it occurs. And also to begin an exercise regimen or regular activities such as walking, working up to about 30 minutes daily. Want to advise the patient of the importance of using their long-acting bronchodilator regularly, and that their albuterol or their short-acting dilator is for limited as-needed use, specifically for the shortness of breath, because excess use of the rescue inhaler can increase side effects, and to provide training for inhaler technique for best drug delivery, which again is a GOLD guideline recommendation. The patient may go ahead and have an annual influenza vaccination today or at his 30-day follow-up to reduce the risk of serious illness, including hospitalization due to lower respiratory tract infection and death, recommended by the GOLD guidelines. And the patient may receive the PVC-13 vaccination now or in March of 2018. However, the PPSV-23 vaccination is not needed until 2022. For the depression assessment and disease, the patient has a HAM-D score of 16, and with his reported symptoms, he would have moderate depression. I recommended to discontinue the planned therapy with citalopram because the previous trial led to erectile dysfunction and diarrhea. Citalopram also has a dose-dependent increased risk in QT prolongation, which the patient has also presented with today. The goals of therapy are to alleviate signs and symptoms of depression and improve the patient's quality of life. And I recommended the patient start bupropion hydrochloride, immediate release, 100 milligram orally daily for 7 days, twice daily for 7 days, then 3 times daily for 14 days. And if the patient can tolerate 300 milligram daily dose, prescription may be switched to bupropion SR, 150 milligram twice daily. The rationale here is that combination with nicotine replacement and pharmacotherapy reliably increases long-term smoking abstinence rates when combined or when used in combination from the GOLD guidelines. Bupropion is FDA approved for the treatment of major depression or major depressive disorder, and a lower dose and frequency is recommended in patients with hepatic impairment. For bupropion, we will monitor safety such as increased heart rate, constipation, nausea, confusion, dizziness, tremor, agitation, anxiety, or dry mouth. There is a drug-drug interaction between bupropion and the metoprolol, leading to an increased exposure of metoprolol. And systemic steroids, although Advair would be considered an inhaled corticosteroid combination inhaler, but we may see that combination leading to a lower seizure threshold. For efficacy, we're going to look for improvement in clinical signs and symptoms of the depression and improvement in the HAM-D score. I recommended follow-up visit in 30 days to assess improvement, repeat the HAM-D questionnaire, repeat general chemistry labs, and assess renal and liver function prior to any dose escalation. For non-pharmacologic therapy for depression, I referred to psychiatry for a discussion of CBT and to consider group therapy sessions. For patient education, we will advise the patient to avoid activities that require mental alertness until the drug effects are known. So start the bupropion when they don't have a need to be driving. Take at the same time each day, preferably in the morning, to help avoid any issues with insomnia. To avoid use with alcohol. If a dose is missed, they can just resume with the next scheduled dose. And to discuss expectations of the time response to bupropion. For example, during the first week, they can hope to see improvement in anxiety and sleep and in appetite. Between weeks 2 to 3, they can hope to see improved energy, concentration, and memory. And between weeks 4 and 8, they should hopefully begin to finally feel the improvement in mood and hopelessness, and if any, suicidal thoughts. And also we want the patient to report any changes in heart rate or blood pressure, worsening symptoms of depression, or suicidal ideation. And that is it. Thank you.